the back of the ambulance and then be like, oh, I'm starting to feel sick, hold on.
And it really doesn't work once you get sick.
No, you have to do it, you have to get it beforehand. So you don't want to get too warm, but ultimately remember that you're there for the patient, you're not there for your motion sickness, right? All right, so here is a key thing. If your patient is hypoglycemic in a hypothermia patient, you have two different methods that you're going to give it. Okay? If you're under 93 degrees, you take your D50 and you put it into a liter bag. Okay? And you titrate that in. You run it in over, doesn't matter how long, however long it takes you to get it's basically just diluting your D50 so it's not a high concentration. Okay? So just so you guys know, this stuff is fair game for scenario now. Okay?
So now you already gave this to us.
Yes, if they're cold, yes. Okay? If they're over 94 or 93 degrees, then you can give it normally.
Don't we usually have 25 grams and 50 mils?
Mm-hmm.
So we put two ampules of D50 in that liter bag to get 50 grams?
Yeah. All right, so here's our pulseless apneic hypothermic patient. Okay? Pulseless apneic hypothermia. Severe hypothermia. So you start CPR. Okay?
After you get them in the back of your bus?
Yep. Or let's say you didn't show up with your bus. Oof, son of a, now you don't even know what to do. You're like, oh, we're here. We can't do anything until the ambulance gets here. Because we know that we have to bring an ambulance, right? Okay, so you start your CPR, right? Start your CPR and you get your pads hooked up, give your shock. Right? They're in VFib. Or what's the other one we can shock?
VTAC.
Without a pulse.
Without a pulse, okay? So it's one of those two rhythms, you shock. Back on CPR for 2 minutes. Okay? We get our airway established. We get our IVs established. What are we going to do with our IVs? Warm fluids. How are we going to package our patient while we're doing our CPR?
Covered as much as possible.
Cover them up. What else are we going to use?
Put things under their
Things.
hot packs.
So we're going to hot pack in the junctions, right? So armpits, groins, back of the knees, as much as we can. We're going to hot pack them, hot pack them, hot pack them. So we got our hot packs, we got our warm fluids going. We got them all packaged up, cocoon style, keeping them warm. Some places will carry warm humidified oxygen as well. We don't here, but Western Lane, I still believe it does. I believe LFA does as well. So we have warm humidified oxygen. It's basically just a metal rod that will go down into a humidifier, and basically it self-heats the oxygen. It's actually kind of pleasant if you, like when you guys start doing your internships and stuff, you can guys play with that stuff. So you get your fluids going, warm fluids, IV access, all right? So if you're below your 86 degrees, what do we do now?
Continue. You can give one drug, right?
Okay, so you can give your one epi.
Below, you're talking about below 86?
Yeah, below 86.
This is with
Right, so we're withholding multi-rounds of medications, okay? So you're giving me one epi, right? One epi, it's in, and it's going to circulate.
We're not doing our amiodarone.
No amiodarone, no antidysrhythmics, no additional meds, one drug, until what?
You get the temperature above 86.
You got to get that temperature up, okay? Until that temperature's up, we're just rolling with this. We're going every 2 minutes. Every 2 minutes, we're just going to come back. We're not going to shock every 2 minutes, but we're going to come back and we're going to do our pause, stop, check, see if we have a change in rhythm. No, back on CPR.
So you're running a PEA protocol.
Yep. Yep, exactly. And so, because you want to get them, because remember, considering our causes, what's one of our causes?
hypothermia.
Hypothermia, right?
And you're only
It's going to be very hard for you as a paramedic not to shock a VFib or a VTAC when you have it there.
You get it once.
What's the reason?
yeah.
Why don't you do it?
because the circulation is not occurring, there's no circulation that's happening with it, so if you get it back, if you change it, if you knock it out, a lot of times what's gonna happen is there's a massive potassium dump in the system, and so what can happen if you get all this potassium in the system?
So, I'm not quite, what's the difference between the lack of circulation of core temperature below 86 and the lack of circulation of somebody who's just in a standard cardiac arrest? Is because of the shunting of the extremities and the
Blood
potassium
flow.
around, almost like a crush injury?
So, let me show you here. Don't look at those, don't look at those. All right, so let's run the other one. So what happens, so the way that's basically, when you're hypothermic, okay, compared to a non-circulatory system, when you become hypothermic, your body goes through a different process, okay? So when it comes to decrease in temperature, your body will start to shut everything down, and then it will start to release some of those cells, will start to release some of the potassium out into the system, okay? So as it starts to release all this potassium, what happens to the system? If there's a lot of potassium,
You're gonna be hurt,
yeah, so you're gonna end up putting yourself, they're gonna put themselves into a massive hyperkalemia. So it's very similar to like a crush injury
okay.
type system. So you're gonna just throw all of this toxic stuff out into the system.
And does that normally happen when your patient starts to come back into like the 86-degree range, you start seeing that?
So as you warm up, as you start to get those rhythms back, it's highly likely that you're gonna present with potential peak T waves, widened QRS, and there is that potential for looking like it's gonna potential hyperkalemia type of a patient presentation.
Would you want to give treating that hyperkalemia?
So that's exactly what you start looking for. You start looking for those things, but knowing we didn't do any sort of antidysrhythmics, boom. So now we start to warm up, so now we're gonna start seeing some of these antidysrhythmics that are gonna start to occur. Okay, so that's what we've showing you some of those dysrhythmics that start occurring down at the mild or moderate level of hyperthermia. Now you're at this severe hyperthermia, and it's gotten to that point where now it's, okay, we have to manage some of these.
So we're treating our patient, we're doing our cardiac arrest, we did one shock, we got one round of epi, and then we're just basically shocking, or I'm sorry, CPR, that's all we're doing. We're running a PA protocol.
Yep,
We're
until they're
warming our
warm.
patient to get them above 86. Once we get to that 86 mark, we start running our amiodarone.
Well, depending on how it
And
presents.
depending on what the rhythm is.
Yes.
You're gonna run that algorithm.
Yes.
And so,
So as soon as they're warm, as soon as they're over 86, you go back to normal ACLS.
okay. And then you're gonna try and treat the hypothermia then.
If they're presenting that way, if they start to present that way.
How often are you checking temperature then?
Every 2
Every
minutes.
2 minutes?
Every 2 to 3 minutes, depending on how much fluid you're getting run in. So if you run one bag of saline in, are you gonna expect a big temp change? No, I would say probably 2 to 3 bags before you start seeing a temperature change,
You're gonna run 3 liters?
roughly.
I just figured out my
Are you,
If you're running this 3 liters, is this with or without, I know it says with full IV medication, but is this with or without the D50?
If they're hypoglycemic, one of them, so
I thought you started talking about D50 for a hypothermic.
nope,
patient.
hypoglycemic, if they are hypoglycemic,
they're hypothermic and hypoglycemic.
yes.
Which is like.
So you're not just running regular,
Okay.
you're not running like D5W,
Okay.
like that's, we're not switching to that type of fluid. It's if they're hypoglycemic in a hypothermic patient, we're not just giving it IV bolus.
Okay, I
We're
got
giving it diluted.
Hey, Chris.
Hey, yes,
Corey was talking to us about choosing one antidysrhythmic
Yes.
and using that.
yes.
In a patient like this, if we're in one algorithm and we're starting, like our next drug would be amiodarone,
Mm-hmm.
do we hold off on giving that until we're sure that they're not hyperkalemic?
Yeah, so, well, I mean, I would say I would hold off. When it comes for your first antidysrhythmic,
Yeah.
okay, or your only antidysrhythmic, when it comes time for antidysrhythmic, that's when you make the determination of, based on what you see, based on the presentation, based on the downtime, what medication you're going to go with it,
Okay.
all right?
But if you see signs and symptoms of hyperkalemia later,
Yep.
you're just, you go
Oh,
with that route.
later?
Yeah.
Later down the road?
Yeah.
But this, the sodium bicarbonate, sodium bicarb is not an antidysphotic. So you can run your antidysrhythmic protocols with amiodarone or mag sulfate for whatever reason, but then you get to a certain point, if they're hyperkalemic, you see it, do you run sodium bicarb because it's not an antidysrhythmic?
I'm going to withhold from answering that.
Okay.
I'm going to get clarification.
And so, I know we don't use, our calcium glutamate, calcium chloride, mag sulfate, and amiodarone to try
Right.
and onslaught them. But my understanding is, because of that conversation, sodium bicarb is not an antidysrhythmic, so we can
The calcium it.
run our ACL's protocol, and then if we select hyperkalemia, we can then put sodium bicarb in. I think.
Right. So I'm gonna withhold from answering that till I get you guys a complete, clear answer on that. Okay? All right.
At 86,
86.
will we start to see all those signs of hyperkalemia if it's present?
Not always. Not always.
Because the blood is circulating.
So, oh, sorry. If it's present. Sorry.
If they're
If the
hyperkalemic,
patient-
once we hit 86, we'll start to see those
as we
peak
start
T
to warm,
weaves.
as you start to warm them up, yes.
So you should maybe expect that to be something to look for, see
Yes.
if it's present, and then choose your,
Exactly.
okay.
Yep. So as you're getting there, as you're warming up,
Yeah.
you're like, hey, it's highly probable, possible, could be hyperkalemia. Let's see what happens. We get to our 86. Are we there? Yes or no? And if you have nothing that has built the case for it,
Yeah.
then you go with your amiodarone. If you have a lot of wide QRSs and peak T waves, you're like, hey, this is actually kind of presenting this way. Let's go that route.
Okay.
Okay? All right.
I had a medic in the ER present with also giving albuterol with our hyperkalemic patients after we pushed our calcium and sodium bicarb. Is that?
Is it the beta agonist or what?
Because she said that it helps to push the potassium back into the cells.
Correct.
So are we gonna nebulize albuterol when we have that patient?
It is in the protocol.
Yeah.
Yeah, nice try, Noah. Yeah.
So
I'm glad you're taking lots of notes, Noah. Paying close attention.
Go ahead.
But yes, it is in our protocol for hyperkalemia patients, so your crush injury, hyperkalemia. It is a very bottom of the thing that says consider albuterol. It doesn't explain why, it doesn't do any of that in the protocol portion of it, but it does have to do with forcing that potassium back in.
Okay.
And so it's just a extra, it's not one of those, hey, make sure you do it. It's one of those, hey, consider this in an attempt to help. Kind of thing. Okay? All right, so if you're unable to get a core temp, if you don't know if they're warm or cold, you have no idea where they're at. Okay? You just revert back to your ACLS. Okay? Even if you're suspecting it, you just go back to ACLS until you can prove what that core temperature is. All right? All right, cool. Let's take a break.